Hello, I'm Dr. Shikha. Welcome to my podcast named Neurology with Dr. Shikha. For my first episode, I have chosen the most classical neurological dilemma, tuberculosis versus neurocysticercosis. Why this dilemma? Because both are endemic in this country, both present with seizures, similar presentation, both can show ring-enhancing lesions on MRI, and both have very different treatment. So our decision and diagnosis matters, because if we unnecessarily treat or give ATT in NCC, it can lead to months of ATT toxicity. And if we delay life-saving ATT in tuberculosis, that can be life-threatening. So I will break it down in 3 steps. There are 3 pillars in making our diagnosis. The first, of course, is the clinical clues, which as a clinician should be our first filter. The systemic symptoms of weight loss, fever, night sweats, lymphadenopathy, and the evidence of any other TB anywhere else in the body, or a history of TB in or around the patient can definitely tilt us towards the tuberculosis. Second clue is definitely the imaging. Now that is the main. So coming to the most important segment of this video, which is the imaging pattern differentiation of tuberculosis versus NCC. So as you can see, this is the T1 sequence with contrast. This is the most informative sequence, and this one which we need to see at first. So first we will see the number of lesion and the location of lesion. If the lesions are many and they are located in the multiple places and in the gray-white junction, that will point towards NCC, multiple gray-white junction lesions. If the lesions are few, discrete, and they are mostly in the posterior fossa, that is seen in tuberculosis. So now coming to the next point. Next point is the size of the lesion and the wall characteristics. If it is more than 2 cm, more likely to be TB. Less than 2 cm, more likely to be NCC. Wall, if they are thin, smooth, more in favor of NCC. Thick wall, irregular wall, more in favor of tuberculosis. And lastly, the conglomeration. Conglomeration is a more characteristic features of tuberculosis, and it is not that commonly seen in NCC. If at all seen in NCC, the walls will be separate for all the cysts. However, there will be merged walls in the tuberculosis. So next we are coming to the flare sequence, which is the most important sequence after the T1 contrast. So we will look for flare suppression, which is very characteristically seen in neurocysticercosis if there is hypodensity in the flare sequence. Edema, marked edema as well as midline shift, more common in tuberculosis. Okay, next feature is that of time. Yes, time. Time is the most important feature, most commonly helping step. We need to follow up the patient's symptoms, and we need to follow up the scans. In the follow-up scan, if we see the lesion size is decreasing and there is calcification, then we can go more in favor of NCC. If the lesion remain the same, they do not resolve, and there is no calcification, think of tuberculosis. So we have done the detailed step-by-step evaluation of TB versus NCC, and lastly cysticercal serology, which is not very definitive, can be supportive when positive, and finally it is a gray zone that we need to see more and more and more carefully to make a diagnosis. So this was Dilemmas in Neurology with Dr. Shikha, signing off today and coming with more neurological dilemmas in the future. Thank you.